All right, good morning. We're close to the finish line here. I'd like to continue the theme that we've had on personalized medicine. I'm happy to introduce Mark Boguski. Mark and I were classmates at Washington University several decades ago now. Mark is an interesting guy. He was using this term bioinformatics when we were in pathology at Washington University, and I go, what drugs is this guy on? You know, where is this coming from? So Mark was doing bioinformatics before any of us even realized how important this was going to be, both to the genomic medicine revolution, but as Mark will continue to portray today, how important it's going to be for the practice of pathology going forward, and particularly for personalized medicine. So there's a great profile of Mark in our book. I'll let him get started since we got up here a little bit late, and thank you all for being here on our closing day.
Thanks, Mike. This is not the first time I've talked at this conference, and so presumably I've done an adequate enough job in the past that you invited me back. So thank you very much.
And you'll be back.
Actually, when I was at this hotel 2 years ago for the annual CAP meeting, I pulled the drawer out. I was going to put my socks away, and the catch was broken, and it fell and broke my big toe, and I limped around. So my memories of the Hyatt in Chicago are a little mixed. But when I got out from the hotel, they gave me $20 for a cab ride to a podiatrist who could treat me. Okay, I guess I have to pull up my presentation here. So I kind of, sometimes I feel I'm paid to be provocative, and I won't disappoint today. We've been hearing about the $1,000 genome for at least a decade, and it's taken on meanings and implications well beyond the original intent, which was to create a technology that could sequence a genome not for $1 billion, but $1,000. We're on the verge of achieving that, but my point today is that it's time to move beyond that meme, if you will. I required conflict of interest disclosures. I'm co-founder of a company called Genome Health Solutions, and my wife, Dr. Michelle Berman, is a paid blogger for MedPage Today. Excuse me. So I'm going to start out with Steve Jobs' cancer timeline. And the reason for this will become apparent in a minute. As many of you know, Mr. Jobs had a pancreatic tumor. Contrary to everything that was said in the press for 9 years, it was not pancreatic adenocarcinoma, but rather a pancreatic neuroendocrine tumor, which has quite a different prognosis than pancreatic cancer. And I think all the misinformation that was presented by lazy reporters who didn't bother to differentiate was a disservice not only to the public, but also to Apple shareholders. If you have pancreatic adenocarcinoma, your life expectancy is quite limited, whereas with a PNET, with appropriate treatment, you can live for 10 or 15 years. So anyway, this cancer timeline was derived from the biography published shortly after Mr. Jobs' death, and it does not violate any HIPAA regulations to show this. But Jobs was diagnosed with this PNET back in 2004 and opted not to have surgery immediately, thinking that maybe alternative medicine might provide the answers for about 9 months. And by the time he was actually convinced by friends and colleagues to have the surgery, that the tumor had spread. Being who he was and who he knew and how much money he had, he was able to have the tumor genome analyzed back in 2004. And back then, it wasn't a $1,000 genome. It cost $300,000 to sequence a genome, so not available to most mere mortals. He did okay for a number of years, but then the tumor spread to his liver, and he underwent a liver transplant in 2009. By the time he underwent the liver transplant, the metastasis or recurrence were subjected to another tumor genome analysis, and by that time the street price had fallen to $38,000 per genome. So Mr. Jobs, because of who he was and the fact that he didn't rely on insurance reimbursement to get this tumor genome analysis, was able to avail himself of this technology. So now that the genome is almost down to $1,000, is it suddenly available to all of us? When we're not the heads of the most valuable company in the world, can us mere mortals actually avail of ourselves of this advanced diagnostic? So the question is, it's 2012 and I have cancer, what do I do? And patients look at the internet, and a patient might say, I've heard that having my tumor genome analyzed may tell me why my cancer is different and what my doctor can do about it. I've also heard on the internet that it costs only $1,000 to analyze my genome. So doc, here's my check for $1,000. Please sequence my genome and use it to choose the right drug for me. So I will talk about why this is not realistic today, and maybe discuss some of the reasons. I will discuss some of the reasons why, and maybe provide some guidance on how we can move forward beyond this. But first, I'd like to contextualize current genomics in the history of medical applications of genomics. I characterize this as using the metaphor of waves. So the first wave of medical genomics, which had its halcyon days in the mid-1990s to the early 2000s, is that the human genome will yield many new drugs. And it will do so because finally we'll know all the potential drug targets, protein, derived from protein encoding genes in the genome, and suddenly we'll have this cornucopia of drug targets for which we'll be able to develop small molecule inhibitors, antagonists, whatever. This was pretty much a dismal failure. Not because of who was in charge. I mean, this was really the province of the biotechnology and pharmaceutical industry at the time. And I think this whole notion was hyped up by the supporters of the Genome Project to continue public interest in the project and public support for it. But some of the people in the applied research and pharmaceutical industries, swallowed this wholesale, and there were many acquisitions and multi-million, tens of millions of dollars a deal to turn the genome into new drugs. And you can count on one hand how many new drugs were actually informed by genomes. The reason it didn't yield many new drugs is because what should have been apparent to people at the time is that having a target is only the very first step. It doesn't mean it's a validated target. It doesn't mean that it has a rational role in the etiology or pathophysiology of disease, and that target validation is often a very time-consuming and expensive process. And so the fact that we had all these new targets actually slowed down drug development, and it didn't really change the overall economics or timeline of 10 to 15 years from a validated target to a small molecule drug in about $1 billion. You can read about these waves in an article, special issue of Genome Medicine, which some of you may be familiar with, but I'll just point that out to you because it's a whole issue devoted to genomic pathology. Okay, what was the second wave? The second wave occurred in the early 2000s until sort of peaked in 2007. And genome-wide association studies were supposed to reveal the underlying causes of all multifactorial complex diseases like hypertension and type 2 diabetes and help us mitigate those diseases. Again, there was much hype here, and this kind of wave, barely washed up on the shore as well. The reason being that the major research finding of the GWAS era was that common diseases are not caused by common variations in the genome, they're caused by rare ones, and so knowing the common variations did not really help very much in either prognostically or therapeutically or preventively managing disease. Nevertheless, a number of direct-to-consumer genotyping companies such as 23andMe, Navigenics, DecodeMe sprung up to medicalize GWAS data, although they never really claimed it was for medical use. It was for educational use only. And some of those companies are, have still exist today and have kind of altered their business plans somewhat. But again, the second wave of genomics was largely disappointing. So if the first wave of medical genomics was the province of the pharmaceutical and biotechnology industries, the second wave was the province, according to the National Human Genome Research Institute at least, of primary care physicians and genetic counselors who would look at your genotype and help you anticipate and mitigate the emergence of common diseases. So now we're in what I call the third wave of medical genomics. And the third wave is precision diagnostics will lead to better outcomes. So whereas the first wave was the province of the biotechnology and pharmaceutical industries, the second wave, primary care and genetic counseling, this is our wheelhouse. This is where pathology makes its contribution. And I'm very bullish on the fact that it's our community that will finally help realize the promise of the Genome Project for its impact on human health. And much of the rest of my talk is about how I think that's going to play out. There's a lot of confusion about genomics, and first of all, let me state categorically that genomics is not genetics. Genomics is not genetics. Genetics is not genomics. Genomics in the pathologist's mind is really about, adult onset somatic diseases like cancer derived from somatic mutation. It has nothing to do with the germline. It has nothing to do with multi-generational inheritance. And you don't need to be a geneticist and know all about Mendel's P's and all of that to practice medical genomics in a pathology department. There is some overlap between genetics and genomics, but they're not the same. As I just described, wave 2 of medical genomics was basically pre-symptomatic prospective genotyping for disease risk assessment. And examples of this are the GWAS stuff that I already talked about. You can imagine it being applied in newborn screening and carrier testing as well. And I don't have time to get into that now, but maybe if you're interested, we can do it during the Q&A. The NIH is very bullish on trying to establish the utility of whole genome sequencing for newborn screening. And there's an RFA out now for grant applications to do that, and there's some pilot studies going on in different groups already. But I don't think that has much to do with us. I think there is a model where pathologists can contribute to this, and again, if we have time in the Q&A, I can go into that. But again, our wheelhouse, our bread and butter is on your right. It's post-diagnostic genotyping for targeted therapy and treatment optimization. It's another way to do tumor subtyping, and it's a way to make therapeutic recommendations based on pharmacogenomics. We mapped out this sort of new paradigm for the laboratory diagnosis of cancer in a publication in 2009. And of course, it always starts with a patient and a tissue specimen or some other kind of specimen, which is given to us to work our diagnostic magic on. And right now the middle row there is still pretty much the good old H&E and some special stains, if you will, and occasionally a single gene or small panel molecular diagnostic. But I think in the future, what we saw happening is that all of this traditional H&E is still going to occur, and maybe some special stains as well. But we're going to preserve a piece of the tumor, hopefully frozen and not fixed, into our magic sequencing machine. And there would be systems that would automate data processing and integration, that would reverse engineer disease pathways for us, and pop out a list of annotated disease networks and drug targets, which could then be communicated to our clinical colleagues in terms of very precise diagnosis. I think that a real opportunity for pathologists is to build on all the work that's been done in systems biology over the last 10 years and take it a step further. Not only give a precise diagnosis in terms of the underlying molecular pathways, but also use in silico methods to simulate therapeutic interventions. And so the pathology report of the future will not just be a textual description of what we've seen in the microscope and a SNOMED code, but rather a data and parameter set with some conclusions that we will present to the tumor board, and if they want to rerun the simulations and make their own therapeutic decisions based on our recommendations or their own analysis is yet to be seen. So I like using case histories. Here's a couple that illustrate some of the points that I've made already. The patient was a 60-year-old man with a long history of tobacco and alcohol abuse who presented at a New York hospital with heart palpitations and difficulty breathing. Physical exam revealed palpable right supraclavicular lymph nodes, and a CT showed tumor masses in the lungs and lymph nodes. A biopsy shown on the left, most of you will recognize that used to be a lymph node filled with little blue cells, but now it's filled with nests of tumor cells metastasized from the primary and the esophagus. The patient was started on standard cytotoxic chemotherapy and referred for tumor genome analysis. Laser captured microdissection was performed on the FFPE slides, and about 20 nanograms of DNA was obtained, which was enough to make sequencing libraries. Following next-generation sequencing, which took about 3 months, cytotoxic chemotherapy was discontinued and the patient started on Gleevec. Now, many audiences I know don't really know what the significance of that is, but we all know that Gleevec is FDA approved for 2 diseases, chronic myelogenous leukemia and gastrointestinal stromal tumors. Would an oncologist ever even dream of prescribing an anti-leukemia drug for metastatic squamous cell carcinoma? No. Okay? It was only the genome analysis that suggested that this patient might benefit more from Gleevec than from standard cytotoxic chemotherapy. So in the next slide, I'm going to show you who the patient was and who the referring physician was, and tell you what the lessons learned from this case were. Patient was Christopher Hitchens, a well-known literary critic, political commentator, and well-known atheist. There he is demonstrating 2 of the cardinal environmental risk factors for esophageal cancer. His referring physician was Francis Collins, who was a well-known theist, if you will. And these 2 folks knew each other from debate, having atheism versus theism debates. And when Collins found out that Hitchens had this disease, he said he recommended that Hitchens might benefit from having his tumor genome analyzed. So the take-home lessons for this is that you have to know someone, and number 2, you have to be willing to pay out of pocket for this because insurance does not cover this. And although physicians are legally able to, licensed physicians are legally able to prescribe drugs off-label like Gleevec for esophageal cancer, the question is whether an insurance company will reimburse for that or not. So there's economic issues here as well as access issues. Here's case history number 2. Patient is a man in his mid-30s who presented with acute lymphoblastic leukemia. Following induction therapy, he received a stem cell transplant from a donor sibling. Unfortunately, he relapsed in 2011. Again, received another induction therapy in preparation for another transplant. However, whole genome sequencing of the patient's tumor revealed that there was minimal residual disease after induction therapy, meaning that a second transplant would have failed. And here's where we get into some of the economic implications of this. Had the genome analysis not been done, the minimal residual disease would not have been detected, and the patient would have received another stem cell transplant at a cost of at least $250,000, which would have failed. So the economic argument you make here is that, okay, maybe we paid $10,000 or $20,000 or even $30,000 for the genome up front, but it saved us $250,000 in what was going to be a failed therapy had we not had this information to begin with. And those are the kind of value cases, the value propositions that we need to start making, not in an anecdotal fashion, but in a statistical one. Anyway, based on whole genome sequencing and transcriptome data and the correlation with drug knowledge bases, additional treatment options for induction therapy prior to his second bone marrow transplant were assessed. Here are the somatic mutations in the patient's ALL cells. None of these were really helpful. Many of them are synonymous amino acid substitutions. There's only one well-known tumor gene there, oncogene neurofibromatosis type 1, but it was a truncation mutation. And I know of no drug or even drug strategy that could rescue a truncated protein, even if that was related to the etiology of the disease. So in this case, the genome analysis was basically useless. However, the transcriptome analysis was a different story. Among the top 1% of all transcripts in this patient's tumor cells was FLT3, which is the CD135 cytokine receptor tyrosine kinase, which also happens to be the drug target for a drug approved for renal cell cancer. Again, would an oncologist ever think of treating ALL with a drug approved by the FDA for renal cell carcinoma? No. So these are the kind of new therapeutic options that can often arise from a whole genome analysis, and which were more and more of these examples are mounting every day. These are not, isolated incidents. We're finding that regardless of the tissue of organism origin, whether you call it breast cancer or pancreatic cancer, there are other driver genes in there that are more characteristically associated with other tumors. For instance, sequencing work on multiple myeloma genomes from the Broad Institute, published about a year ago, showed that about 4% of myeloma genomes have the BRAF mutation. And again, would you ever think of treating multiple myeloma with a BRAF inhibitor? So anyway, Here's one of the obstacles again to the medical use of that $1,000 genome. The patient had to be treated off-label with the drug at an unreimbursed cost of $330 a day for 12 weeks. And unless you can pay for that out of pocket, you're kind of out of luck. Nevertheless, the therapy worked. Patient was in complete remission and underwent a stem cell transplant on December of 2011. Does this case sound familiar to anybody? It was written about by Gina Kolata in the New York Times a few months ago. The patient was actually a Hem/Onc fellow at Washington University in St. Louis, my alma mater. And one of the docs who took care of him, a medical oncologist named Tim Lay, a friend of mine, said that because of the publicity surrounding this case, about 20% of the patients that come into his leukemia clinic ask if they can have their tumor genome analyzed for targeted therapy. And again, I'm not violating any HIPAA regulations here because this was all published in the New York Times. People who came to my talk at the last conference have seen this slide before. I just want to use it to remind you that when we talk about the $1,000 genome, we're only focusing on one thin slice of this pie. It's really the bottom left quadrant there. It's only the technology. But there are many other considerations, there are many other stakeholders, there are many other things that we have to solve for if the $1,000 genome is ever going to be translated into a broad-based diagnostic intervention. In fact, if you know someone, and if you have relatively deep pockets, you can access this in a concierge medicine-like fashion, but it's going to cost you between $25,000 and $100,000 to get a tumor genome analysis and find an oncologist who's willing to treat off-label based on those results. So there's only a handful of people and places in the world where you can get this done. It is available, but you have to know someone, and you have to be maybe not among the 1%, but certainly well-to-do enough that you could afford this. The top right quadrant there is medical education, and I'll just remind you that we recognized this problem a number of years ago in our program at Beth Israel, and started a mandatory training program for our second-year pathology residents in personalized genomic medicine. And the fact of the matter is that there simply aren't enough medical geneticists to deal with the problem of medical genomics. And in fact, their training is not even appropriate to the major uses of medical genomics, at least in our purview. Medical geneticists, their training typically consists of learning about how to diagnose and manage pediatric onset Mendelian disorders. They know very little about cancer because actually most cancer is not familial, it's sporadic. So it's really our job to take this on. Now, I made the mistake maybe of showing this slide to the talk I gave at the annual meeting of the American College of Medical Genetics a couple of years ago. And during the Q&A, someone got up and said, well, there may be 17,000 pathologists out there, but only 100 of them know what DNA is. And so my rejoinder to that was, of course all pathologists know what DNA is. It's just another analyte, right? Something we measure. Nevertheless, maybe the 100 FTE estimate for people who actually know enough about how to interpret sequence data and have the bioinformatics expertise to process and understand it, maybe they were right about that. And so we took that as a challenge that pathologists working, nonetheless in conjunction with our colleagues in genetic counseling and medical genetics have to join forces to even approach a credibly sized workforce for genomic medicine. Just think about it in terms of the number of newly diagnosed cancers in the U.S. every year. It's somewhere between it's about 1.5 million. And can you imagine 1,000 medical geneticists who really aren't trained to deal with cancer, being responsible for the tumor genome analysis of 1.7 million cancers a year? Not going to happen. So I think pathologists, we can be in the driver's seat if we play our cards right. And the reason is this: laboratory services make up only about 5% of hospital budgets, but influence 60 to 70% of all subsequent clinical decision making and the medical spend associated with that. So we're really gatekeepers for major economic impacts on the healthcare system. Unfortunately, new technology is usually a major driver of increased healthcare spending, and so we have to be very careful when we're to make the value proposition when we want to introduce, even gene panels by next-gen sequencing, for instance, into clinical practice. Will this actually help or hurt not only patient outcomes, but also the economics? United Health predicted that the diagnostics market will increase from $5 billion to $25 billion in the next 10 years. Part of the reason for this is Clay Christensen's observation in his book, The Innovator's Prescription, is that in the past, the relative value of therapeutics and diagnostics have kind of been like this. But as expensive targeted therapies are being developed and achieving increased scrutiny from insurance reimbursements, the FDA and insurance companies are demanding companion diagnostics that select that subset that's most likely to benefit from expensive therapies. And so what that is, it's shifting the proportion, the relative values of therapeutics and diagnostics. Diagnostics are going to be much more important in the future for precision medicine, and that's part of that increase from $5 billion to $25 billion. So my challenge to you, to our community, is how are we going to get our piece of that? Right? Because if we don't have a plan, if we don't figure it out, someone else is going to eat our lunch, and I don't want that to happen. So how do we do that? One of the ways is through comparative effectiveness research. Pathologists are in a unique position to conduct a comparative effectiveness research and evidence-based technology evaluation. Here's my general model for comparative effectiveness research. In the boxed, dotted line box in the upper left is current standard of care. A patient presents with a cancer, a biopsy or resection is done, and a battery of standard FDA-approved molecular diagnostic tests are applied to it. And what those companion diagnostics, in the context of targeted therapy mean is we have an annotated drug target. Okay, you have the BRAF mutation, you get verapamil. We can do the same analysis using not one or two genes at a time or gene panels, but whole genome analysis. And I think we need to directly compare, in a comparative effectiveness research framework, the cost effectiveness of doing it both ways. As many of you who are molecular pathologists know, very few single gene tests cost less than $1,000. And by the time you stack up about 5 of those, you're already in the ballpark of doing a whole genome. And isn't that going to be more cost effective in the end to do the whole genome, but do a targeted interpretation based on what's actionable in that genome? But we need to demonstrate that. We need to demonstrate sample adequacy. Actually, our whole standard operating procedure for handling surgical specimens and biopsies are frozen is better for molecular testing. It just is, particularly for RNA. And we will probably have to change the behavior of surgeons who will submit our samples to God knows how long of dry ischemia time in the OR before it even gets dropped into formalin. And I think it's a soup to nuts transformation of the way we view medical care, and I think it's going to require new kinds of alignments between surgeons, medical oncologists, and pathologists, with some patient involvement as well. And that's not going to be easy. What I learned in industry is that change is never about technology enablers of change. It's all about change management. It's getting people to behave differently using the new technology. So anyway, I think this is really critical. I think we as pathologists are in a unique position to carry out this comparative effectiveness research, and I'd like to see much more of that happen. So in Forbes back in June, Jim Golden published this article called Cancer Data and the Fallacy of the $1,000 Genome. The time of the $1,000 genome meme is over. It has served us well for years, driving advances in instrumentation, chemistry, and biology, but now it is reducing clinical credibility. You really can't get anything, clinically significant out of a $1,000 data production exercise. It requires all those other pieces of the pie to make it work, at least on a broad scale. And it's time for the $1,000 genome to leave the lexicon of healthcare. It has to go. The good news is that if we play our cards right, Jim Golden concludes that pathologists will be the future data rock stars of healthcare. But what we need to do is we need to educate ourselves on the fast track. We can't expect practicing pathologists to suddenly take 2 years off from practice and go do a molecular pathology fellowship. We need to empower people with decision support systems, CME, to bring them up to date within the next 2 years, I think, or we're going to be at a risk for losing a major piece of this. My model, just in the closing few slides here, I have a model for the management and utilization of big data in pathology. PathCloud has already taken the domain name, is owned by somebody else, so we can't use that. But there are all these technologies out there, and I think one of the implications here is that Because of intense marketing by the technology providers, they're telling us not only why we should use their instruments, but how, and that's upside down for me. It's us who will know how to contextualize this, how to use these appropriately. Comparative effectiveness research will provide data to back us up. So we can't be swayed by the latest wave of technology platform fashion. We need to think about not what the technology providers are telling us it can do, but what it really can do today and tomorrow, and how we're going to get paid for it. So I think any solution like this is going to have to be device agnostic. And I think furthermore, any concept like this is going to have to be solution agnostic. Dedicated hardware for this and proprietary data types, I think, are going to be an impediment to the system. I'll just end with 2 acknowledgement slides. This is a group of visionaries and thought leaders who we got started on this problem a couple of years ago. I'd like to thank them, including my chairman, Jeff Saffitz, in the middle, and many folks from either the head or representatives of many of our pathology professional organizations. And I'd also like to thank my business partner, Rich Kellner, on the bottom left there, who has taught me 3 things. It's how to think about building data-intensive solutions. It's how to think about change, catalyzing change in the face of disruptive technologies. And last but not least, in fact, most importantly, he's an e-patient himself with a family history of cancer. He's taught me that it's not going to be pathologists, it's not going to be alone, it's not going to be technologists or necessarily even oncologists to change this. It's a new collaboration. It's a new relationship between patients and pathologists that I think is going to drive this change forward. Thanks very much.
So, Thanks, Mark. We aren't going to have a panel at the end, so we'll take questions now on Mark's presentation. So, Mark.
Thanks.
Just step aside here, Bill's going to walk.
Hey, Richard.
It's nice to say goodbye to memes as well as to welcome them. But I have a question for you, talking about who's going to eat our lunch, talking to people who are trying to think about how to bring this into a practicing medical system. They're completely daunted by the costs and by the lack of trained personnel and just by the informatics overload. So I'm wondering who wants to eat this lunch? It seems like a poisoned chalice.
What you're seeing now is the emergence of a lot of companies that, without being too pejorative about this, kind of relegate the role of the pathologist to dropping a tissue block in a FedEx envelope, sending it off to a central lab, and getting some report back where we have no intellectual input really into the process. And I think that's a sad development for the field. If we're just sort of paper pushers or block pushers, that doesn't satisfy me as a pathologist, and I think it's kind of an affront to our tradition of being the diagnostic enablers of personalized medicine. So there will be commercial solutions, there will be laboratories that are providing this that will, purport to, take all the headache and away from you. I think if we are seduced by that, it's going to be a mistake for the profession. I think we have to develop our own methods, our own ideas, our own tools to make this forward. And I think in the end that will continue to guarantee our place in the value proposition of healthcare.
From the point of view of an economics, I suspect it's the top 2%, because there's always, when there's an economic opportunity, it could be covered by insurance if the premium was high enough. Mm-hmm. I also suspect that if 1 or 2 hospitals would actually do this, the top 1 and 2% would come up with the dough pretty fast. Mm-hmm. And go in and will not be worried about the cost. There is a market for Rolls Royces. Mm-hmm. The social advantage of this is that we would get the data.
Right.
And the data is the most important part because that benefits all of humanity.
So I don't disagree with anything you said. In fact, we're probably in violent agreement about that. It's just, how do you do that? Most cancer care is delivered outside the 63, NCI cancer centers. 80 to 85% of cancer care is delivered in community hospitals, diagnosed by community pathologists, and those are the people this can't be a province of grant-subsidized academic research only, or it's not going to affect the majority of cancer patients in the world. So we've got to develop decision support tools and systems to educate those private pathologists out in the community, those non-academically aligned pathologists out in the community, and we have to give them adequate decision support tools so they're not tempted to just send this off to a reference lab. That's a choice they can make if they don't want to do it locally, but that's my view on it.
Earl Roth from Chicago. Thank you for a great overview of where we are and where we're headed in personalized medicine. While it is true that there are about 17,000 pathologists, a great part of what we're talking about falls into the purview of clinical pathology. Mm-hmm. And the species of a clinical pathologist seems to be endangered, largely because in anatomic pathology, the income is fairly predictable. Mm-hmm. Not so in clinical pathology. Mm-hmm. When you finish medical school with $200,000-$300,000 of debt, you look for an area where you can pay off that loan as quickly as possible. Right. How do you see the incentives for going into clinical pathology changing?
So, I'll address the economic, incentives in a minute, but first let me say that I see conceptually, I see the boundary between AP and CP disappearing because, more and more of these tumor genome analysis are being done on cytology specimens and brushings, and technology is converting, to put it one way, is converting solid tumors into liquid tumors for us, and so the traditional roles of anatomic pathologists and hematopathologists and clinical pathologists are blurring. And with apologies to Karen Call, I will say that in the future all pathologists will need to be molecular pathologists. It won't be a subspecialty anymore because it's cancer diagnosis. And again, just like the medical geneticists, there aren't enough molecular pathologists or training programs to ramp up in time to apply this broadly to the population. Economically, I think that I don't have an answer for that, but I will refer to the fact that I think we should start talking to patients more and finding out what they want, because I think this technology is not going to be driven by physician acceptance, it's going to be driven by patient demand. And patients can go anywhere in the world these days to get their genome sequenced, and unless we take it on, those patients are not going to get as good service by medical tourism, and they may even be hurt by it. So I think it's a challenge for us to figure out how we do this economically. Mm-hmm.
Good morning, Paul Epner, Evanston, Illinois. In the traditional world, diagnosis of the condition is a start and a stop point, and then it moves on to treatment selection, whether it be procedures or pharma. I think what you've outlined is it's going to get very blurry as to when, after diagnosis of the disease, there's diagnosis of effective treatments. Mm-hmm. And so I wonder how you think this continuum of diagnosis, is there a stop, and a start and a stop, and will we have a new workflow in terms of diagnosis in this new world?
Right. So this is an example I've used before, not in this talk, but if we can get the cost and quality and turnaround time down, optimized, tumor genome analysis will not be done once, but multiple times during the course of the natural history of a disease for diagnosing reason for therapeutic failures, tumor progression, and recurrences. And so to do a genome analysis, or a new genome analysis of a tumor or a recurrence or a biopsy specimen will be as routine as a follow-up PET CT scan for monitoring the disease over time. And as cancer becomes less of a lethal disease and we transform it more into a manageable chronic illness, there'll be, I think, needs and opportunities to do multiple genome analyses and continue to guide therapy along the way.
Mm-hmm. Yeah, I just wanted to echo your comment about if frozen tissue is what's better for doing the genome analysis, it is amazing how poorly our pathology infrastructure is prepared to put that tissue somewhere and freeze it.
So I got consulted on a case a few weeks ago where I was talking to the surgeon who was about to do an excision, and I said it would really be helpful to freeze half the tissue. He said, well, we don't have the facilities to do that here. I have to go down to my local beer distributor and get some dry ice. You know, so I agree with you.
Well, I
The
mean,
infrastructure
well,
is...
you know, maybe they could get a hold of liquid nitrogen
Right.
at, you know, a major teaching institution, but then where do they put it after they froze it? It's,
Right. Well,
it was, we had a patient several months ago, we were trying to get some tissue frozen, and it was a major fire drill to get it done.
So again, if you just focus on the sequencing instruments, it doesn't solve the problem. You need a biobank, either locally or regionally, to store these tissues.
All right, take Karen's question, and then we'll move on here.
Yeah, I'll be quick.
Yeah, I'm going to hide behind the podium, Karen.
Nice talking, thanks so much. Karen Call, Evanston, Illinois. You know, frozen is great. Two comments and a question. Frozen is great, but we need to be able to go in and accurately microdissect. And so and it's such a hard amount of work to get,
Right.
you know, the system to do that. So what we really need is some sort of fixative, maybe alcohol Vicks that works with all of our systems.
Yeah,
We're really turning the whole world upside
Yeah,
down.
yeah.
On molecular fixatives. And there are a few things out there, but you know, it's expensive. We're not using them yet.
Yeah, a formalin is still cheap,
So,
right? Of course, in cancer, death is cheaper too, so,
True,
but...
true. So, and great talk, I appreciate it, but we all need to be molecular pathologists. You know, I think there aren't
Okay,
enough
so-
of us to go around, and so I think, you know, the thing I talk about when I speak often on molecular topics is we need to own this. It's
Yeah.
like immunostains, where when we were residents, this is
Yeah.
a technique, and we need to own it and learn it and teach it, and that's, I think, what many of us in the field are trying to do, because, you know, there's not enough to go around. The question I've got for you is to get down to the nitty-gritty of who's going to analyze the sequence data. We have a lot of discussion about this in pathology educational communities, and there's not enough time in residency to teach that. It's a real special skill set. Even the molecular genetic pathology fellowships don't have enough
That's
time to teach how to really mine a genome. So who do you see actually sitting down, you know, with the screens and the databases and converting this to
Yeah,
clinically useful
so
data?
two answers, and one's an analogy. I mean, we rely on PhD-trained clinical laboratory professionals to do a lot of the stuff that we, you know, that we're professionally responsible for, and I think there's going to be bioinformatics and pathology informatics people who will be specialized in this too, and we'll use them, we'll work with them in the same way we work with PhD clinical laboratory folks.
Thank you.